Well, hi there. My name is Mark Santillan. I am one of the maternal fetal medicine specialists here at the University of Iowa Hospitals and Clinics. I want to thank you for joining us for our Facebook Live event centered all around preeclampsia. So good morning, good afternoon, good evening from wherever you're hailing from. I got a chance to take a look at where people are coming from. We got people coming from Dubai and the UK, so thank you. And we hope that this is going to be a very engaging hour to talk about something that we're all very passionate about. Before I was taught good manners, so before we even start, I'd like to start off by saying a few thanks and introductions. So first of all, I'd like to thank Kara Bolt and her group, the Preeclampsia, Eclampsia Help Survivors Facebook group out there. It's 10,000 strong of a whole bunch of international women that have been affected by preeclampsia. Thank you very much. We've gotten your question. We got a whole bunch of questions from you guys. We really appreciate that, and hopefully we'll get to address most of them. We've got over, what, Lindsay, 100? Something like that? And I'd also like to thank Brenda Warner and her group, the Shelley Bridgewater Dreams Foundation, who personally, for me, have sort of shaped my passion as well as fueled my need for this education and advocacy in preeclampsia. So thank you guys. And one more thing, a special thanks and introduction to my friend Lindsay Douglas, who will be the disembodied voice that you hear. She's going to be keeping me on track because if any of my friends are out there, you probably know that I could probably rattle on a little bit. So she's going to keep me on track and make sure that we're trying to address all of the questions that have been sent to us. So with that, let's get at it.
Great. Thanks, Mark. I'm going to throw up an easy question to start. Can you explain what an MFM is?
An MFM, well, that's me. MFM stands for Maternal Fetal Medicine Specialist. What that is a specialized OBGYN. So for me, in order to study, to become an MFM, I did 4 years of medical school. I did 4 years of a general OBGYN residency, and then I did 3 years of a fellowship focusing on the treatment and research of high-risk pregnancies, women, and their babies. And for kicks and giggles, I also got a PhD to do the research that I do now because I'm a glutton for punishment. So, but that was just for fun.
Great. Now let's get into it. Can you explain what preeclampsia is?
Great question. And I think this is something that's really important because I think there's a lot of perspectives as to what it is. And if you are confused out there in Facebook land as to what preeclampsia is, don't feel bad. There's a lot of myths as to what it is. So, what is preeclampsia? Well, preeclampsia is a specific high blood pressure disorder in pregnancy that has a whole bunch of different symptoms that go along with it. So preeclampsia, when people say, I got preeclampsia, I want you to think about it, and I'm going to refer to it as sort of a spectrum of disease. It ain't just one thing. It could be a whole bunch of different things. And so if I could just take a few minutes to at least maybe lay down some definitions that might be important for all of us to understand. So the first one being chronic hypertension. So basically, if you have high blood pressure that starts either before your pregnancy or before the 20th week of your gestation, that's considered chronic hypertension. After 20 weeks, if you just have high blood pressure without any symptoms, without any proteinuria or protein in your urine, that's considered gestational hypertension. You often get kicked up to this diagnosis of preeclampsia when we have other things that get involved. So one of the diagnoses, one of the criteria that we used to use to diagnose preeclampsia, and we still do, is something called proteinuria. So your doctor may ask you to collect your urine for 24 hours, which sounds like a lot of fun. But we measure the amount of protein that is floating around in that urine. Another way they can do it is they can do a dipstick, or they can do a different test called the protein to creatinine ratio. That proteinuria traditionally has made the diagnosis of preeclampsia if you had both hypertension and that after 20 weeks of gestation. Having said that, in 2013, the American College of Obstetrics and Gynecologists revisited what we think about preeclampsia. And you no longer need to have that proteinuria, or that protein in the extra protein in your urine, to actually diagnose preeclampsia. So you could have preeclampsia without the protein in your urine, but you have to have some other stuff. So you have to have abnormalities in your labs, like whether or not there's evidence that your liver is damaged, or there's problems with your kidneys, or if you're having pretty bad symptoms like really bad headaches, seizures, or any significant pain. And so it's like I said, this is a spectrum disease from chronic hypertension to sort of preeclampsia without severe features, preeclampsia with severe features, and then among the more severe types of preeclampsia are things that we call HELP syndrome, which I think many of you actually sent us questions about, which is hemolysis, elevated liver enzymes, and low platelets. Obstetricians aren't all that creative, and so HELP sounded kind of cool. So HELP syndrome is probably, if it's a spectrum of not so great to really bad disease, HELP is in the spectrum of preeclampsia that's really bad disease. And some women get really, really sick. And if you're interested in, if you've never heard of HELP syndrome, I would have you link up to our website. There is a video from a woman called Kelly Carlson, which is a friend of mine now, who I treated a while back with really severe HELP syndrome. So she actually gives us a really great perspective as to what that looks like. And then among the severe forms of preeclampsia is also eclampsia, which is actually having seizures that are associated with blood pressure. So that's sort of the spectrum of preeclampsia. I think I hit it right, Lindsay?
Yes, you did.
Okay.
Could you talk a little bit more about that timeline, and at 20 weeks, 24 weeks, when can diagnosis be made?
That's great. And there's some really smart people out there in Facebook land that ask a really important question. Because there's this diagnosis of when can you diagnose it, right? Technically, you can diagnose it, as I mentioned before, after 20 weeks of gestation. In truth and in practice, most preeclampsia we see later on in gestation. So kind of, the late second trimester, early first trimester. We can diagnose it as early as 20 weeks, but often the traditional preeclampsia that we think of as truly preeclampsia maybe starts peaking up at around 24 weeks. The 20-week diagnosis is a bit of an artifact of the old diagnosis of preeclampsia, but the truth is, if you go see your doctor with symptoms of preeclampsia and your blood pressures are through the roof, not only are we going to think about preeclampsia, your obstetric provider may think of other things that could look like really bad preeclampsia, like lupus that could affect your kidneys, or there are certain tumors in your adrenal glands that sit right above your kidneys that can cause your blood pressures to go sky high. So they're kind of zebras, but they're often things that we think about when you have really, really bad preeclampsia that early on in gestation. So the truth is, it can be diagnosed as early as 20 weeks of gestation, but that's often something else.
Great. And can you talk a little bit about postpartum depression? Postpartum preeclampsia.
Postpartum preeclampsia, great question. I know there's a few people that actually asked about postpartum preeclampsia, and we can get into kind of how you treat preeclampsia, but if preeclampsia is somehow associated with the placenta, and a placenta that's not working so hot, it would make a whole heck of a lot of sense if we deliver the placenta and the baby that the preeclampsia goes away. But in truth, that doesn't. That in some people that doesn't happen. And in truth, we're starting to recognize this a whole bunch more, that we're seeing a lot more people with postpartum preeclampsia. So just think about preeclampsia, all the symptoms that we talked, all the kind of diagnostic things we look for, the symptoms that we look for, but without a baby and without a placenta. And sometimes what that may reflect is the disease process of preeclampsia, the stuff that causes preeclampsia, could have already been released by the placenta or some other organ. And just cause preeclampsia even after the delivery. So that can happen anywhere from immediately after delivery to about 6 weeks of gestation. I'm sorry, 6 weeks postpartum.
Great. And if you're just joining us, we are with Dr. Mark Santillan talking about preeclampsia. And I just want to mention there are quite a few questions coming through, and we will get to a lot of these topics throughout our conversation tonight. So if you don't hear your question right away, I assure you we will try to get to it at some point. You've talked a little bit about the signs and symptoms of preeclampsia, the protein in your urine being a former kind of telltale. Can you explain what causes the protein in your urine?
Oh, that's a great question. Let me back up again just so I could reiterate it, because I don't know if I said it clear enough in terms of the symptoms of preeclampsia. So if you are pregnant, you often, unless you carry with you a blood pressure monitor all the time, you may not know that you'll have high blood pressure. But some of the things I often tell my patients about is, and what everyone here at UIHC tells their patients about is, if you have a headache that doesn't go away with just taking Tylenol or taking a nap, you should tell your doctor or you tell your obstetric provider. If you have blurry vision that's persistent, you can't get rid of it, you need to tell your OB professional. Or if you just feel like poo, to be perfectly honest with you. I've certainly diagnosed preeclampsia in a lot of women who I knew were at high risk, and they said, you know what, Mark, I just feel horrible. I just feel bad. And then that starts the workup. Also, what you could have is some pretty significant upper abdominal pain. And now, this is not the pain that you would feel with, a baby being a ninja in your belly and trying to kick your liver. It's usually pretty intense pain. And what I've had some women tell me is that pain that's related with inflammation and problems with their liver often feels like their appendix burst. It's really, really bad. So those are the common symptoms. You can also have swelling. So swelling that that all of a sudden, over a short period of time, causes you to gain a lot of weight. So your question was?
What actually causes the protein in your urine?
Thank you for reminding me, Lindsay. So the protein in the urine is often part of the central causes of preeclampsia. I could speak for another 5 days about what causes preeclampsia, because the short answer is there's a lot of conflicting ideas, and we could talk for days about that, like I said. But the protein in the causes of the protein often have to do with the changes that happen in the kidney. So there are actually structural changes that can happen in the kidney that doesn't let it filter the protein as well as the kidney should, and so that's how it gets lost in the urine a lot more.
Great, thanks, Mark. Let's move on to some risk factors of preeclampsia.
Oh, okay.
Who is at risk for developing preeclampsia, and what are some of the most common risk factors?
So the common risk factors. So you got to think there's kind of two groups, right? And if you think of preeclampsia as your garden variety sort of cardiovascular disease, those risk factors still apply. So if you're a woman and you look like me and you got a little extra weight, and you and you could stand to lose a little weight, that could be a risk factor. So things like obesity, having diabetes, having chronic hypertension, having a genetic or acquired reason why you might clot a little bit more, having a history of preeclampsia, a very classic medical school question, like, what's a risk factor for preeclampsia or anything, is having had it before. But yeah, family history is important. But then what is sort of interesting too is that women with their first pregnancy with a person is actually at their highest risk of developing preeclampsia in any time of their life.
That's very interesting, and we had quite a few questions come through about specific correlations, and so I'm going to run through some of those.
Okay.
The first coming from Adrian, who asked if there's a correlation between autoimmune disorders and preeclampsia.
So that association is there. Some are, like I mentioned, one of the most common autoimmune disorders is lupus, which I mentioned before. Lupus can affect the kidneys and cause hypertension. So yes, particularly with lupus, there's an increased risk of having preeclampsia.
Great. And is there a correlation between recurrent pregnancy loss and preeclampsia?
So that one's a little bit tougher. Certainly people who have had a recurrent, just because you had recurrent pregnancy loss doesn't necessarily mean you are at risk for preeclampsia. It all depends why you had those recurrent pregnancy losses. Can having high blood pressure and having really uncontrolled preeclampsia lead to a pregnancy loss? Yes. And so it all kind of depends on the mechanisms.
And Maria asks, do you believe that low progesterone levels prevent healthy placental formation and therefore have an impact on a woman's developing preeclampsia?
So that's a good question. Certainly, progesterone is important in the early building of the early placenta, very early on the first trimester. But there hasn't been any evidence to show that if I give a woman progesterone, that will decrease the risk of preeclampsia. Now, in the world of research, I know many of you watching Facebook right now are not rats and mice, but there are some preliminary basic science data that would suggest that if you give progesterone to some mice, that it may flip the switch on preeclampsia. And what I mean by that is it may change some of the mechanisms molecularly at the molecule level that may actually cause preeclampsia.
And Sylvia asks, is there a link between oral contraceptives and preeclampsia?
So there isn't necessarily a direct association. Now we know that women who are not pregnant, well, one thing's for sure. If your oral contraceptives work, you won't get preeclampsia because you won't get pregnant. But even outside of pregnancy, we know that oral contraceptives are associated with hypertension because estrogen in of itself has been associated with clots and hypertension. And so that's the part of it that is associated with hypertension specifically.
And why is gestational diabetes a risk factor for developing preeclampsia?
So it kind of goes along with the whole, from a nerdy science guy like me, a lot of the mechanisms overlap that cause diabetes and preeclampsia. A lot of it has to do with placenta that is not working correctly. If you think about diabetes, often what are risks for diabetes and risks for cardiovascular disease in general, not even in the pregnant state, they're fairly similar. So somebody with hypertension or somebody who's obese will be at risk for both. And so a lot of it has to do with the way the vasculature and the blood vessels are made.
And then Leslie asks, does taking iron supplements during pregnancy for anemia increase the likelihood of preeclampsia?
I am not aware of that data, and women are certainly at increased risk of getting anemia in pregnancy, regardless of preeclampsia. So we have a lot of our women on iron supplements, and so that data is not clear, and I don't think there's an association there.
Okay, and we had a couple of questions about the statistics or data on whether a baby's gender has an effect on preeclampsia chances.
In the research world, this is a really cool question, mainly because we don't have a good answer, in truth. So it depends. The short answer is it depends on who you read. There are some studies that would show in this population that preeclampsia is more associated with females, but in this population of the world, it may be associated with boys. The truth is, it's probably a wash in the end, but that kind of highlights, when I'm talking about these different populations, it highlights the heterogeneity or how preeclampsia can be different, not only as a spectrum of disease, but even in different populations.
And do fertility drugs have an impact on getting preeclampsia?
Fertility drugs. So not specifically fertility drugs in and of themselves, but we know that women who need help with their fertility and have to undergo artificial reproductive technologies such as in vitro fertilization and some of the manipulations that happen there, we know that those people have an increased risk of preeclampsia, and that has to go into the kind of the basic mechanisms of what causes preeclampsia.
And Lauren asks if PCOS can cause preeclampsia.
So PCOS is often along the same, kind of walks along with diabetes in a sense. It's a metabolic syndrome, right? It means that you can't process sugars as well. You tend to be a little bit more obese. And so those risk factors that kind of go along with PCOS are the same risk, and the symptoms that go with PCOS kind of go along and feed into the risk of preeclampsia. So in that sense, yes.
So after discussing all of these risk factors, what can women do to reduce their risk?
I did mention oral contraceptives before, because if you don't get pregnant, you can't get preeclampsia. But the truth is, you know, that's kind of a hotbed of research right now. What can we do? The only thing that's out there that the United States Task Force and the Society of Maternal Fetal Medicine and the American College of Obstetrics and Gynecology and basically any society that that takes care of pregnant women is aspirin. So taking a baby aspirin a day after 12 weeks of gestation till the time they deliver is typically what we do here at the University of Iowa in someone with a high risk of preeclampsia.
And there were some questions about what constitutes a high risk versus a moderate risk of preeclampsia. Can you explain the difference? A lot of that has to do with whether or not you have one of the risk factors that we talked about before. So if you do have already chronic hypertension, because one of the incarnations of preeclampsia that I didn't talk about earlier is that you can have chronic hypertension with what we call superimposed preeclampsia. So preeclampsia just right on top of it. It's a tricky diagnosis, but this is something that that is important to figure out in between. So. Okay, and quickly I'm going to jump right back up to risks. We had Adrian comment on our Facebook and ask if there's an increased risk for preeclampsia if you have endometriosis.
So there's, I am not aware of any sort of association specifically with endometriosis and preeclampsia, and it's not one that we often cite in clinical practice as a huge risk factor.
Okay, and then going back to the aspirin talk, Christy had submitted a question about if you need a higher dose of aspirin, what does that higher dose mean? Is it the frequency? Is that the amount that you're taking?
So that's actually an excellent question because it's honestly a very hot topic right now in the research world and in those who are doing clinical research in aspirin and preeclampsia. So what has been out there for many years is this idea of just taking baby aspirin once a day. There's been recent studies that have looked at people at higher risk of preeclampsia defined by something called a uterine artery Doppler. If you're at higher risk, some studies would suggest that you actually should take more than that. Basically 2 baby aspirins a day. That's newer data, and in truth, in clinical practice, physicians like myself and my other colleagues, we're still trying to figure out what's the right dose. So I took a chance and talked to my friends in the Preeclampsia Brain Trust, a lot of friends across the nation who are treating women with preeclampsia, and a lot of people are in general giving 1 baby aspirin that starts at 12 weeks and then taking 1 daily and ends at the time of delivery.
Are there any other options besides aspirin if you are allergic to aspirin?
Wow, that's a great question. Not really. In truth, we don't have anything that's been thoroughly shown that'll actually help. That's a great question. And I've certainly had women who weren't supposed to take aspirin for lots of different reasons. They weren't supposed to take aspirin because they had surgery on their belly and was afraid that they may get a higher risk of ulcers. I've certainly had women who I thought were at higher risk but didn't put them on aspirin for that reason alone, for not just an allergy, but they shouldn't be taking aspirin.
Great, and I just want to take a moment to welcome anybody who's just now joining us. We are with Dr. Mark Santillan talking about preeclampsia. We've covered the symptoms and risks, and at this point we are going to move on to future pregnancies after having preeclampsia and future likelihood. So we had a lot of questions come through of one variation or another. Basically, if I've had preeclampsia, will I have it again?
Well, the answer is, will I? Maybe. That's the answer. You're certainly at increased risk. So depending on who you read, there's some older data that would seem to suggest that if you had preeclampsia at term, your risk of getting, so closer to 37 weeks, your older data would suggest that your risk of getting preeclampsia again is at the 30% range. Okay, and don't quote me, these numbers vary. So I guarantee you I could find papers that refute these numbers. But just to give you an idea of what this means, if you have preeclampsia in a previous pregnancy that was diagnosed, very early on, so a more severe form of the disease, so right around 24 weeks, 25 weeks, around there, the recurrence for preeclampsia is a little bit higher, maybe in the range of 40 to 50%. So the true answer is yes, you're at increased risk of getting preeclampsia because you've had it again. Having said that, there is some data to suggest, and this gets into the weirdness of preeclampsia. Remember I was talking to you about a little bit about what causes preeclampsia and the different risk factors. So we have the people that look like me. If I was a woman, I'd be at risk for preeclampsia. But then there are people that are young, healthy, and then they get pregnant for the first time and get preeclampsia. And they don't just get the normal preeclampsia. The woman I had mentioned before, Kelly Carlson, whose video is on our website, I would encourage you guys to take a look at it. She had a really severe form of preeclampsia. She was young, healthy, but yet almost lost her life, had liver enzyme problems. Almost every organ failed. And so we think that the cause of that sort of preeclampsia could be an immunologic one, meaning so if my wife is watching, she'll laugh at this and probably and back me up on this. Sometimes men are the problem, to be perfectly honest. So think about it. What's growing inside of a woman during pregnancy, that cute little thing that a woman is growing, isn't necessarily 100% them. It's half genetically them, but half genetically this other guy, right? And so think about what a liver transplant is, right? You think of a liver transplant, they try to match it as, if someone's getting a new liver for whatever reason, they try to match it genetically as best as they can to the patient, but there are some things that are different. And what does the body do? It rejects it. And so a liver transplant patient has to take medicines to calm down the immune system. What we think is going on with preeclampsia very early on is that the normal calming down of the immune system is changed in preeclampsia, and we don't have the immune system calmed down, and so that's how we get rid of it. Did I answer the question, Lindsay?
I believe so.
Okay.
Next question is, how long should you wait before trying for another?
Ooh, that's a good question. There's a lot of, so how long should you wait after preeclampsia? So there's actually some really cool data on this. So from the hallowed halls of the New England Journal of Medicine. This is an older paper, about 2003. And this kind of links in with this whole immunologic idea, because if you have, there's lots of evidence epidemiologically, meaning if we count a whole bunch of people who have preeclampsia or not, if you have a baby with a particular person, and then you have another baby with that same person in another pregnancy, your risk for preeclampsia goes down. But if you have another baby with a different person, your risk for preeclampsia goes back up. So it's that idea of immunology. It's the of kind of being vaccinated against men. I know it seems like a weird concept. And so there is data to show that that protection of having of not getting preeclampsia with the same partner goes away in about 10 years. So just from preeclampsia, we often tell people to try to kind of, if there are modifiable risk factors such as weight, high blood pressure, diabetes. If there are modifiable risk factors, we often try to tell people to get those under control. There's not really a singular one time frame. Now, that we say you should get pregnant now. We often tell women that you should wait a year, 18 months before you get pregnant again to let your body do its own kind of control-alt-delete, to restart itself, to reboot, so that it can be ready for another pregnancy. Now, if you have a C-section, that's a completely different, that's a clearer ball game. If you have a C-section, we often tell women to not get pregnant 18 months or 24 months so that you have time for that scar to heal. And having preeclampsia certainly puts you at increased risk of needing a C-section.
Great, and we have a couple of questions that came through before the cast and even a few on the comments now. If you were to get pregnant again after having preeclampsia, what risk management strategy should I take?
If you say it again, sorry.
So if you were to get pregnant a second time or a third time after having preeclampsia, what risk management strategy should I take?
So in terms of, again, healthy living, it's always an answer for everybody. But there's no prescripted like diet you should follow at this point. There are lots of different diets that people have tried to push, but there's really not one singular diet that is so healthy eating. Certainly, if you've had preeclampsia before, your obstetric provider should absolutely talk about prescribe and tell you to take aspirin on a daily basis in order to decrease that risk of preeclampsia. And then I think this gets lost, but advocating for yourself and knowing these symptoms. I think many women, and usually being the only guy amongst many women, I know women often will kind of downplay their symptoms because they're too busy doing a whole bunch of other stuff. And I think advocating for yourself and remembering that these are the symptoms of preeclampsia are really important because I have a mom and I'm married and I have a wife that will say, I've got other things to worry about. I've got these other issues. I don't want to worry about them. And I'll figure it out later. No. So I think knowing these symptoms and advocating for yourself, I think are pretty good strategies in terms of trying to avoid risk. But at the same time, we don't have the 100% predictor of preeclampsia.
And we had a couple of questions about if I had preeclampsia before, should I be seeing a high-risk obstetrician or MFM for future pregnancies?
I think it's reasonable for you to at least, consult a maternal fetal medicine specialist. Now, it's obstetric care and pregnancy care for women is delivered by many different, very qualified obstetric providers. Okay, and a lot of that has to do with how comfortable a group is in taking care of preeclampsia. Here at the University of Iowa, we have literally everyone under the same umbrella. We have anywhere from medical students to, not that they're taking care of you, but from anywhere from residents to family practice doctors. We have certified nurse midwives. We have general OBGYNs, and then we have maternal fetal medicine specialists in the spectrum of kind of expertise in OBGYN. And everyone is under our roof is very comfortable with these really high risk things. So a lot of it has to deal with what is that practice, or what are those obstetric providers comfortable in dealing with. And at the same time, the place where you're going to deliver. Sometimes preeclampsia can get really bad. You may need 20, 30, 40 units of blood if you have severe preeclampsia for whatever reason. And so being in a place that is equipped or having a place being in a practice where they know their limits of when they can, what they can take care of, and know when to ship off to a higher acuity institution would be something that would be very helpful.
Great. And for women who've had preeclampsia before and they're planning on having another baby, when they meet with their local doctor or MFM, what are some important questions to ask?
I think some of the things are, if they've had preeclampsia before, particularly if they're the severe kind, I think it's important to understand what the capabilities of the institution at which you're going to deliver, right? As I mentioned, if you had somebody who was like my friend who came close to death, and then other friends who have died and lost their battle with preeclampsia, because that particular area didn't have the resources, didn't have the 40 units of blood they needed, or didn't have the type of surgery, didn't have the ability to do the type of surgery that needed to happen right then and there, then I think those are important questions to ask your provider. Now, these are in the most extreme cases, and unfortunately, I couldn't tell you, and no one can tell you, this is going to be the pregnancy where you're going to get rip-roaring, horrible preeclampsia. That's a really hard thing, but you've got your risk factors. So I think it's, I think this is just an honest conversation with you and your obstetric provider as to what are the capabilities of the practice and what are the capabilities of the institution at which you're going to deliver.
Great, thank you. And if you are just joining us, I want to take a minute to welcome you and thank you for your questions that are coming through. We are with Dr. Mark Santillan discussing preeclampsia, and let's move on to the long-term effects of preeclampsia. We have a lot of questions about this, so let's just start off with what are the long-term effects of preeclampsia on the mother?
That is a great question, and I think this is sort of an opportunity, number one, for us to understand what that means, and number two, to kind of highlight where what we're missing in medical research. So women who have preeclampsia are at increased risk of future cardiovascular disease, including heart attacks, deaths related to heart attacks, stroke, diabetes. Any of these vascular problems, women are at high risk of. And there are some data to show that the more severe your preeclampsia was during your event, the higher your likelihood of that happening. One of the things that, as a, with my researcher hat on, and my advocacy hat, is trying to convince people that this preeclampsia is not, and I repeat, it's not just a pregnancy disease. It is not just a woman's disease. Babies born to those moms underneath those preeclampsia pregnancies are also at increased risk of cardiovascular disease in the future, anytime from up to 2 times higher risk. So this isn't a public health issue. This just doesn't affect women. If the baby's a boy and had a mom who was preeclamptic, that boy is going to be at higher risk of developing hypertension versus someone else. And so this is something that I think often gets lost in the talk about preeclampsia, because this is not just a mommy disease. It's an everybody disease.
And when you talk about the babies born to moms with preeclampsia,
yep,
we've got a couple of questions about daughters born to moms with preeclampsia. Are their risk higher for preeclampsia in the future if they were to get pregnant?
So in the sense of preeclampsia, we haven't identified a gene. Let me answer this in a different way. Preeclampsia does run in families, and so there are certainly grandmothers that had what we used to call toxemia, but that's the old term for preeclampsia. They got toxemia, and then their daughters had preeclampsia. So we know that there is some sort of genetic contribution, but we haven't gotten our fingers put on that yet. So are they increased risk? Yes, but the absolute risk, I couldn't quote you a number, because it all depends as to why. And some of this has to do with this immunology thing that we talked about before. Sometimes if you have a particular sequence of this that is not compatible with somebody else's sequence that you got pregnant with, then it may be the same sequence in grandma and her daughters.
Great, and you talk a lot about severe preeclampsia, and you've touched on it a few times. Could you just explain what severe preeclampsia is versus standard preeclampsia to
right.
those who may have just joined?
Okay, thank you for that question. So yes, if you got preeclampsia, there's the term we used to use is mild versus severe preeclampsia. We don't use that terminology anymore, simply because we think all preeclampsia is important. So all preeclampsia matters. The important thing is that the terminology we use according to the American College of Obstetrics and Gynecologists is preeclampsia without severe features and preeclampsia with severe features. So preeclampsia without severe features tends to be hypertension with that proteinuria stuff and some maybe mild and occasional mild symptoms. Now, severe features would equal a higher blood pressure. So in the realm, systolic blood pressure is in the 160s. Some of the things that we had talked about before, liver enzyme problems, so evidence of liver damage, kidney problems, where you're not urinating as much, headaches that don't go away, seizures, severe abdominal pain. So that's why these symptoms matter, because you may have a normal blood pressure, well, not a normal blood pressure, but a preeclampsia level blood pressure, let's say 150 over 90, which is technically in the mild range. And let's say you don't have proteinuria, you can certainly still be called preeclamptic if you have things like headaches that don't go away, that are banging, and really bad abdominal pain. So this is something that has actually made the diagnosis for preeclampsia a little bit more liberating, because it used to be a lot of providers used to hang on to that definition of proteinuria and needing it. And so, and we know that you can use it to diagnose preeclampsia, but it's not necessary.
Great. And going back to the long-term effects of preeclampsia, what health problems should we be screened for and when? Okay.
So this is again another opportunity for more research in the future. So the American Heart Association in 2011 added a history of preeclampsia. And this is pretty groundbreaking in the sense that they added preeclampsia as a risk factor for future cardiovascular disease in the same category as obesity, smoking, hypertension, diabetes. So it's at a level playing field. So if you think about what you should be screened for, it's the usual stuff. Make sure that your weight is under control. See a doctor every year for follow-up. In terms, so they could check your lipids, in terms of your cholesterol, in terms of your sugars, in terms of your blood pressure, all of that. So unfortunately, we don't have a soups to nuts explanation or prevention for future cardiovascular disease in those who eventually get preeclampsia, who have preeclampsia and its effects afterwards. And so what is currently being recommended is that in terms of seeing a doctor, see a doctor every year to get screened for kind of lipids, blood pressures, and your sugars, and weight, of course.
Great. And we had a question from Brandy who said, I've heard a lot of patients with PTSD after diagnosis of preeclampsia. How common is this, and what can be done to treat it? Anything other than counseling?
Brandy, thank you for that question, whoever Brandy is out there in Facebook land. I think this is a realm of preeclampsia that I know that those of you who are tuning in know that this is an important venue, because we just don't talk about it as much. There is a reason why Cara Bolt has a Facebook group of about 10,000 women with a history of really bad, or with a history of preeclampsia, because a lot of that is sort of self-medication, and a lot of it is trying to deal with what just happened to them. So the quick answer is yes. Women who experience preeclampsia are at increased risk of developing post-traumatic stress disorder, as well as depression and anxiety. So these are associations that we know that are out there. And so I think as medical professionals, whoever you are out there, I think it's important to address that in future visits with your patient, because it is part of their life. We're here to not only help you with your physical well-being, but also your mental well-being, and it's something that's certainly there with preeclampsia.
Great, thanks, Mark. We have about 15 minutes left in this hour-long Facebook Live, and with that, we will move forward into some questions about current research. We had a lot of questions about this, but one in particular from Ashley, who asked, is there any new or current studies on the detection of prevention of preeclampsia?
Do I know Ashley out there? Because I mean, it seems like a setup for the stuff that we do here at the University of Iowa. So yes, so there's a lot of research out there looking at newer markers and predictors and diagnostics for preeclampsia. One of the things that people have been looking at for a long time is something called S-FLIT PLGF. You don't need to memorize that. I won't quiz you on that. But it's basically things that control blood pressure. I mean, not blood pressure. Control blood vessel control. Did I say that right? They control blood vessels. And so there are some tests out there where if you have symptoms of preeclampsia, it's got a pretty good prediction. If you've got the symptoms at the time of where you're concerned with somebody might have preeclampsia. Now, I live in Iowa. I have to assume that a whole bunch of people out there in Facebook land live in places very similar to Iowa, where we're predominantly a rural state, and your access to a place that could deal with the severe stuff that could happen with preeclampsia may be limited. And so wouldn't it be cool if we had something that was where we could predict preeclampsia as early as the first trimester, as early as someone gets pregnant. And so this is not ready for prime time yet. Certainly the work that is happening in my lab and the stuff that we're doing here at the University of Iowa, we are investigating a marker for preeclampsia that is we have published is highly predictive of preeclampsia as early as the 6th week of gestation. So this is as soon as a woman can find out that they're pregnant. They go, I think I forgot something this month. And so we know that this protein can be found in the blood as well as the urine. So we're currently working on industry partners to help us put this out in the market. And so, of course, this is not ready for prime time. In addition, there are a whole bunch of other markers that are at the time of diagnosis, when things are getting there, that where there are symptoms like things like congophilia, and these are words that maybe many of you may not hear, but there are lots of markers at the diagnostics. But the early detection of preeclampsia often falls in some of the work that we're doing. In fact, there is actually some good data that came out of the UK looking at an ultrasound measurement called a uterine artery Doppler that is pretty good at predicting preeclampsia around 10 to 13 weeks.
Great. And for some of the people who are just joining, there are a couple of questions about HELP, and if you could just reiterate the connection with preeclampsia and HELP for some of those speakers.
Sure. So HELP syndrome is not separate of preeclampsia. It's sort of a part of the spectrum of preeclampsia. And if this is just normal, plain preeclampsia without severe features, HELP is, on the other hand, as one of the more severe forms of preeclampsia. It can be diagnosed when you have what the name says, HELP, H-E-L-L-P. Obstetricians can spell. It's just, it was a cool way for us to remember it. Hemolysis, so your blood kind of breaks down a little bit. L-E-L, elevated liver enzymes, where it's evidence of your liver dysfunction. And then low platelets, so you're not making enough of the things that are floating around your blood to help you clot. You don't necessarily need to have all three of those things to be called HELP syndrome. There was a paper written some time ago that HELP syndrome may actually be He syndrome, or LUP syndrome, or L syndrome. Regardless, if you have any of these laboratory abnormalities, it is enough to kick you into the realm of preeclampsia with severe features if you've got high blood pressures as well.
Great, and moving a little bit into current events, we had a couple of questions submitted about your opinion on the new AHA guidelines on high blood pressure.
Ooh, really good question. The answer is, I'm not sure yet. It's a good question. Certainly, so to recap for a lot of you, the American Heart Association has actually suggested that the blood pressure, so 140 over 90 is often considered hypertension in both non-pregnant or pregnant states, right? So the idea is that that gets decreased down to the realm of, in systolics, 130 blood pressure. So from a science standpoint, and what we think is we're probably going to pick up a lot more people. And I recently read an article saying that this may just say that about 50% of us here in the United States will have some sort of level of hypertension. So what is this going to mean for us dealing with taking care of women with preeclampsia? We don't know yet. Certainly the diagnosis of preeclampsia hasn't changed yet, and it's still 140 over 90 is high blood pressure. But there's lots of evidence that is out there to show that the tighter we control blood pressures, the better outcomes go. And that's like a linear fashion. So you lower your blood pressure, the better your outcomes are. And so this may open up some of the research out there in terms of starting to look at, well, what does 140 or what is 130 in a preeclamptic or somebody who is hypertensive look like? Because certainly that would be in the realm of concern if someone is in, let's say, the third trimester with that.
Great.
Not ready for prime time yet, though, so let me be very clear about that.
And when you say prime time,
it's not clinical practice yet. Thanks, Lindsay. I've known Lindsay for too long, so she knows when to correct me.
Getting into a little bit more of the advocacy realm of things, we had a question: how do we get an ACOG task force guidelines to be referenced and implemented by clinicians and institutions? What can we do as lay people to increase this awareness?
Well, I think a lot of that has to do, I mean, I think from a national standpoint. So I work at some national levels at some institutions like the Society of Maternal Fetal Medicine. Many people at our department here at the University of Iowa were our recent president of the American College of Obstetrics and Gynecology, Tom Gelhaus, was actually in our department. And so a lot of these individuals have pushed this out in the stream. And thank God for social media, and thank heavens that we have the ability to hit the net with all of these data. But at the end of the day, it's the access is out there. All of this is, you could Google this. If you Google ACOG, ACOG 2013, or ACOG hypertension in pregnancy, I guarantee you the 100+ page document about it will come up. So I think a lot of this has to do with, I think a lot of obstetric providers out there already know about this, but it's not a bad idea to, discuss this with your obstetric provider and, let them know that you too are advocating for yourself and know a thing or two about preeclampsia.
Great. And at your about 8 minutes left.
Okay.
And so I just want to kind of touch on some more random off-the-wall questions that kind of don't fit into a category here. We had one from Leslie come through. Is preeclampsia truly determined upon the implantation of the placenta, or can it develop later on?
The answer is yes to both. So one of my dear mentors, actually several of my mentors from a preeclampsia group from where I learned from, Chris Redman, also Jim Roberts and Les Myatt. These are kind of international heroes of preeclampsia and my gurus. Chris Redman actually, they've taught me, and Chris Redman actually published a paper looking at the placenta in different ways. So can the determination of preeclampsia happen at the time of implantation? Absolutely. There's a lot of papers coming out of the UK for Ashley Moffat. There's a paper looking at mom's particular immunologic sequence for something and baby's immunologic sequence for something. And I'm not going to get too nerdy about it because it's easy for me to get nerdy about it. That if those aren't compatible, that really increases the risk of mom to get preeclampsia, and that's that immunologic thing. So that's determined even before, that could be determined in theory before pregnancy. But the hypothesis that Dr. Redman and actually Dr. Staff from across the seas also talk about is the fact that the placenta needs nourishment. And when it runs out of nourishment, I think he calls it the potted pot hypothesis, in the sense of when the placenta is running out of resources, it starts to dysfunction. If it's getting too big, or if it's not getting what it needs to feed the baby, it starts to dysfunction. It's that dysfunction is literally the core of preeclampsia.
Great. And what are your thoughts on bed rest? Yay or nay?
Nay. So, and I don't mean to say that facetiously. Are there associations, some associations with kind of activity and preeclampsia? Not so much. But in terms of bed rest, there's been no evidence to show that confining someone to bed and not moving actually helps anyone. And it may only put you at increased risk of developing a clot in your leg. So sometimes people will say, take it easy. And sometimes if we have women whose blood pressures are sky high, and it's difficult to control, well, if they can't control it and they're sky high, then that may be indication for delivery. But sometimes we tell people to just take it easy, but not bed rest. I never prescribed it, bed rest.
Great. And after almost an hour of chatting about preeclampsia, it's clear that you are passionate about this topic in your practice and in your research. Why preeclampsia?
Wow. I mean, that's so let me indulge me a little bit and let me tell you a little bit of a story. So when I was in medical school, I had a family that had some of the similar things that many of you out there have had. They, mom, his first baby, kind of a taller, bigger woman. I took care of them throughout their entire pregnancy. And then she got severe preeclampsia. And to be honest, it scared the hell out of me as a medical student. And I went to medical school. I did my residency in the same place where I did my medical schooling, and I saw these people again and again. And thank God that they delivered. They delivered, and mommy was healthy, but she was really sick. And I think it's this constant urge to get back to that woman to see, man, I wish I could fix it for you. I really wish I could. And so I think in my practice, this is what is always running in my head. And so as with my clinician hat, that's what's running through my head. Can I fix it for you? But with my researcher hat, I get to do some really cool things that may actually get to that point. So at the end of the day, it's not because I want to be world famous. It's not because I always go back to that one person that I met in medical school, and I still think about her every day. And so I am incredibly fortunate to be surrounded by many women like her that reminded me that this advocacy is still really important. Educating patients like you out there and women like you out there, and educating physicians and nurse midwives and anybody who takes care of anybody pregnant, and anybody who just is concerned about women's health, and not just women's health, everybody's health, because preeclampsia affects everyone. And so being able to do that gives me energy, and I'm surrounded by women, and I'm surrounded by advocates of this, and I'm so fortunate that I get to do that through many of the foundations that I've been lucky to be involved with. And so the true answer is it was that one patient, and for many people, I guarantee you, for whatever people get passionate about, it's usually that one patient.
Great. Any final thoughts or recommendations for our group tonight?
Well, in terms of some final lessons, I feel like I'm at the end of a talk show. It's kind of weird. I would like to remind people out there, particularly the women that have had preeclampsia, I want to remind you that it's not your fault. I deal with a lot of, and I'm fortunate, I get to care for a lot of women here at the University of Iowa, and the overwhelming theme is that women think it's their fault. It's something that they did. It's nothing you did. Okay, it's something that we need to but there are things you can do to help prevent it again. So know your symptoms. I encourage you to advocate for yourself, and there are some old practices out there. I won't lie to you. There are some old practices out there that maybe need to get changed, and I hope that will, as the education flows from something like this and through many venues out there, especially through the University of Iowa or other venues, that those practices will soon change to actually help fix preeclampsia. And so don't forget about these symptoms that we've talked about. It can be a tough diagnosis, but be persistent and make sure that that people know that you know. So with that, I would really like to thank you for this opportunity. I feel blessed that I get to do this and talk to you about something I'm uber passionate about. I love this stuff, mainly because I love the people behind that camera. I love those women that actually bring me their stories and tell me about how things have gotten better. That's the sort of fire that's the fire that fuels me. And so thank you, Kara Bolt, for kind of publicizing and with your Facebook group. It was a pleasure to talk with you all. Thank you for chiming in. If you have any other questions, feel free to kind of follow us on through uic.org and follow this link and follow us on our Facebook page. We'd be happy to answer any other questions as we go along. But other than that, that's all I got. And if you guys have any other questions, we're here. So thank you so much for your time, and hope we'll see you around again.